My name is Golkoo Morcos. I am a medical science liaison at ViiV Healthcare, and part of my role is to educate the community, work with providers as well as patients in the area of HIV. And so today I'll be doing the formal presentation, but I'm joined by these wonderful women who are going to, we're a panel, so if there's questions, we've got Mary, we've got Dr. Singh, and we've got Bridgette as well. So I'll hand it over to you guys to kind of introduce yourselves and kind of give a background about what you do, who you are.
I'm Mary Dorsey, and I am a person living with AIDS since perhaps 89, when I got married to a person who had AIDS and I didn't know it. And I couldn't deal with it until I joined LKA and was able to socialize a little bit. And I'm here if you have any questions.
I'm Dr. Singh. I work at Desert Days Project as primary care internist as well as infectious disease specialist. And I'm here to give the perspective as a physician for HIV aging and females.
My name is Bridgette Picou. I'm a nurse at Desert Days Project. I'm also a person living with HIV for about 5 years now. So I'm here for kind of the nursing perspective, and I see myself as an advocate for my patients.
Okay, wonderful. So I see a wide variety of folks here. Just by a show of hands, how many of you are pretty comfortable with HIV and women? The topics that women, okay. All right, so that's good because this presentation is really one that sets some foundation of knowledge for women who are living with HIV. And so it's actually geared towards women who are positive, kind of giving them some guidelines and some direction in terms of how they can take care of themselves, how they can make informed decisions about their health and their reproductive health. And then end of the presentation gets into aging with HIV and how that may affect women. So since most of you are pretty experienced, some of this might seem a little bit just like as a review. So if you do have questions or you have any comments, I would encourage you to just raise your hand and we'll address them as we go through. And if it's a clinical question, I'll hand it over to Dr. Singh. If it's a question, and Bridgette as well. And if it's a question related to people living with HIV, Mary, Bridgette can probably answer those questions as well. So we're working as a team today. Okay, so the one thing about women is that we tend to think of everyone else before we think of ourselves. And if we're living with HIV, this is a lifelong condition and it requires going to clinic visits, it requires taking medications, being extremely adherent. And there can be a lot of obstacles oftentimes in women's lives that are slightly different than others. And those are managing children, managing partners or spouses, carrying a job. Perhaps there are income issues, so they don't have transportation. Maybe there are cultural obstacles and they aren't able to tell their families, or they need to hide that they're positive from their partners and so on. So all of this becomes crucial because our ultimate goal is for patients to be successful on their HIV therapy, to be thriving, regardless of their diagnosis. And so hopefully this presentation will just give you some overview and some guidelines on the kinds of things that positive women need to do or can do in order to achieve that. So the first part of this is how women and their healthcare providers should think of themselves as a team. And in today's age, and maybe Dr. Singh can speak to this as well, people would go into the doctor's office, they would just basically, the doctor would diagnose them, they said you need A, B, and C, this is what you need to do, and people would say, okay, but we've come a long way since then. We have technology, we're able to look and research things on the computer, and it's also really important when you're living with HIV that you have a provider that understands you, that respects you, that's willing to work with you collaboratively in making treatment decisions. And that you feel encouraged to ask questions, to not be afraid to explain things clearly to them, to be able to feel comfortable enough to discuss personal topics like sex or domestic violence. So we know that women living with HIV as well as transgender women as well face domestic violence or in a lot of cases. So, Dr. Singh, anything to add to that?
Just that, when they come in for the first time, establish a connection, a chemistry with the patient, and let them know that you're safe here. You can tell us what you need. The patient preferences are very important because my goal might be to get them suppressed virally, and their goals might be like, how am I going to live with this? What am I going to do? How will I tell my partner? What happens to my children? Will they get it from? So to have a collaborative team approach from the very beginning where tell me what I can do for you instead of telling them, okay, let's start you on this medication today. I will see you back in 4 weeks. Let's get this labs done. It's a little bit more important when we're dealing with our female patients to have that connection from the get-go.
Yeah. And Mary and Bridgette, do you have any comments as well in terms of getting, say a positive woman is coming into care for the first time, or maybe they've been seeing a provider for a while, they're just not that comfortable. Any advice or kind of guidance you can give around that?
It's really, really important that you have some sort of connection with your provider, be it just that you love them or that you respect them, because it's easier to follow a plan of care when you have that connection with them. The other thing is sometimes, particularly for women, it can be difficult to find a provider that can do both your primary care and your HIV care. Some providers that strictly do HIV do only HIV, and some primary care providers are not comfortable doing HIV care. So it's okay to have a collaborative team, but it's really important that you make sure that whatever your primary care provider is prescribing for you, you're discussing with your HIV provider and vice versa, so that you don't end up with medication interactions or mix-up, and so that you get the best care that you can. And it's okay to shop around for a doctor if you're not comfortable with the doctor that you have, because you do need to be able, like Golkoo said and like Dr. Singh said, to discuss all of those different issues, sexual health and things like that. So you need to have that relationship.
Yeah, a lot of my patients, my female patients, they will ask me that I would talk about their PAP. When was your last PAP and everything? It's like, oh, I don't remember or whatever. I was like, well, this is important, but I do both. I can do your cervical PAP as well as anal PAP. And so let's get you to do some of this primary care stuff that has been kind of neglected. And they love that. They're like, oh, so I don't have to go and elsewhere? It's like, no,
Yeah.
I can do it.
Right. Yeah, it's definitely advantageous to have someone who can do all that for them and has experience specifically treating women, right, with HIV.
Absolutely.
Mary, any comments?
My comments is how grateful I am that medical care for women has come so far from the beginning. Because the first time I went to a doctor, she asked me, "How are you going to pay for this?" And there was no help at all. So it's just amazing to how far we've come.
Okay, great. So, again, some of the points that we already stressed and Dr. Singh and Bridgette also mentioned. So, it's important to be able to have these women keep their clinic appointments. And so, a variety of things are happening in these women's lives. Like I mentioned, they've got family, they've got work, they may have income issues. So, if you're at a clinic that may be not providing clinic hours that are flexible, that may be something to consider, especially if you're seeing a lot of women come in. You might want to think about, okay, what are their schedules like? Do we need to open up a night clinic to be able to address getting some of these women in here? Obviously, if once they're diagnosed, they're going to have their blood tests being done every few months, generally speaking every 3 to 6 months if they've been suppressed. Understanding the reason that they're taking their HIV medications, and of course that the medications are not a cure for HIV or AIDS. However, hopefully maybe within this decade we'll get there. We've got a lot of cure initiatives going on with the NIH and other companies working on that, so it's a very exciting kind of time to be in, I think. And then if you're on treatment, it's important to take medications exactly as a healthcare provider prescribes. This is really, it's such a basic thing. But, I'm a pharmacist by training, and I've taken my medications incorrectly. Actually, this is one medication I was supposed to take it 4 times a day, and I misread it, and I thought I had to take all 4 at once. So let's not talk about the side effects, but just simple things like that, you would, and this becomes an issue, right? Because adherence is at the forefront of HIV, being successful on HIV therapy. You know, if you're not adherent, then you of course have the chance to develop virologic failure, and the consequences of that are developing resistance. And at this point, we have limited classes of antiretrovirals, and we're concerned that patients, you know, if they're not taking their medications appropriately, then they're going to limit their future treatment options. So I don't know, Bridgette, Dr. Singh, do you have any recommendations when you have patients come in and you think adherence might be a problem, or let's say they're a newly diagnosed patient and you're starting them on a regimen? What are some ways that you can encourage adherence or help them understand how to take their medications?
If you tell them very clearly, listen, take this pill in the morning with your breakfast, and try to do it every day around the same time. If you give some clear-cut, clarified, instruction, that helps. If you just say take once a day, then they're like, oh, okay, well, I guess I can take it anytime. So very clear, this is how you take it, with or without food, or if you, and then we have a MyChart, so they can communicate with us via electronic portal. And so let me know in about a week or so if you're not tolerating this. Give your body to adjust for about a week. And then if you're still having some side effects or like severe side effects, give me a feedback. Let me know. I'll see you sooner than maybe I'm seeing them in 4 weeks or 3 weeks or something.
Do you find that if women are experiencing side effects from medications that they're starting, that they're likely to just say, you know what, I decided to take my medications, it wasn't making me feel very good? Or do you think that women tend to, generalizing, but do they tend to put up with the side effects and not talk about them?
I haven't necessarily noticed the difference that way. I think the people who are going to, there's not gender differences that I've noticed.
I think it's interesting in the HIV space, especially when we talk about side effects. I mean, all medications, especially HIV medications, have side effects. And there was a study called the HOPE study, and it was looking at communication between patients and their providers around the kinds of issues that they're facing with their regimens. And it was clear that there was underreporting of side effects, actually. So patients, HIV positive patients, weren't telling their providers that they're experiencing a particular side effect. And they actually attributed this to a sense of guilt that the patient feels. I'm positive. I know that these medications are going to come with side effects. It's just something that I have to put up with as a result of me, becoming positive. And so it's really important, I think, for providers to have a proactive discussion with their patients around how they're feeling. And, maybe on paper they're suppressed and they're doing well, and maybe they are taking their medications exactly as prescribed, but maybe there are underlying issues around tolerability, or maybe it's not the perfect regimen for their lifestyle and everything. So luckily now we have a lot of different treatment options. So, and all of them have great efficacy, so we can kind of tailor regimens to people. And then of course we know, depression, alcohol, or drug abuse, it makes it difficult for a person to become adherent to their medications. And this kind of goes back to the topic that we mentioned, feeling comfortable with your healthcare provider. To mention that, hey, I'm feeling depressed, I may have a substance issue or an addiction issue, and feeling as if your provider's not going to judge you for that, but rather help to work with you to find a way to make sure that you can be successful on your medications. Okay. So managing other health issues, again, this is pretty basic, but we know that the HIV virus, it causes inflammation throughout our bodies, okay? And if we have comorbidities like heart disease, diabetes, and depression, these things can amplify that inflammatory process. And so it's important, again, for everyone, not just HIV positive folks, but especially for HIV positive, to think about managing a healthy diet, exercising, obviously avoiding the use of drugs, limiting alcohol, and managing stress. And I think specifically for women, stress is a huge issue because, again, they're juggling so many different things in their personal lives that oftentimes their own health comes last. And so, again, these are very basic kind of recommendations from managing stress, like get some exercise, laugh more, connecting with others, friends and family, learning to say no when you're too busy to help. This is a tough one for women. I feel like we are people pleasers at heart. You know, we're caretakers, natural caretakers, and so it's difficult for us to say no to people. Getting enough sleep. So that one is an important thing because the body is regenerating itself during sleep. And a lot of crazy things can happen if you have insomnia, right? You start hearing things, you start seeing things. I mean, it happened to me when I had my babies and I was hardly getting any sleep. I was having these auditory hallucinations. It was pretty crazy. So doing something creative, asking for help. Bridgette, do you think that there's at DAP that there is some good support groups for women around some of these ways to manage stress and ways to encourage women to do these kinds of things? Can that kind of program be implemented at other clinics?
There's actually a lot of support groups that DAP offers. There's a gardening group. There's quilting. There's a ton of things. Tai Chi. We have yoga. These things right here are really, really important, and I can't stress them enough because as women, we tend to ignore these things, whether it's out of fear of people thinking we're not taking care of our business or we're not taking care of our families, or if we can't take care of ourselves, how can we take care of anything else? So we internalize a lot of things. And so it's really important that you find, if you don't already have, a good support group or a good circle of friends. I'm a big advocate of having a hobby. Something that you love to do, something that makes you feel good as a person, because that helps you deal with a lot of the other things that you have going on. So anything on this list is fabulous to start with. But it's really, really important that you find that sense of something outside of yourself to help settle yourself, that makes yourself feel good so that you can take care of yourself.
Mary, how about you? Do you do any of these things, or do you have any recommendations?
Well, I'm pretty super motivated of taking care of myself, and before there were medicines, I started doing cleanses, which I'm still doing to this day, to kind of reset how I eat, so I eat better, more vegetables, more fruits, things like that. The side effects is something that when you don't have a good relationship to the doctor, it's very difficult, and they want to keep you on a medication even though you shouldn't be taking it. I went so far as to have Botox to eliminate the headaches from a medication, and I just finished paying my copay, for that. And I had to find a new doctor to get released from that medication. So you shouldn't settle for side effects and a doctor you can't relate to. And sometimes you have to, but there are a lot of good HIV doctors. So.
Actually, you made a really interesting point. Back to that HOPES trial that was done, they also looked at kind of how providers address when side effects are mentioned. And it turned out that the trend was ending up prescribing more medications to alleviate the symptoms that are caused by other medications, instead of digging a little bit deeper to see, okay, can we maybe change some of these regimens to, instead of adding more burden in terms of pill burden and other types of medications you have to take to get rid of some of these side effects. Okay, positive setup. Safer sex, obviously an important part of preventing the spread of HIV. Again, this comes down to education, and we would be surprised that, sometimes women aren't as informed as we think that they are. So again, counseling them on condom use, using a dental dam, every time you have sex, and regardless of the type of whether or not it's vaginal, anal, or oral sex. An additional point is that using condoms helps prevent this spread of other sexually transmitted diseases. So right now, we are seeing kind of, I honestly want to say, an exponential increase in the number of sexually transmitted infections that are coming in across the country, especially in hot spots, it could be Palm Springs, San Francisco, Atlanta, these areas, and it's because people are forgetting about STIs. They're like, okay, we've got PrEP, we can avoid, getting HIV, but oh yeah, all of these other sexually transmitted infections. So we are seeing more syphilis, we're seeing more gonorrhea, and sometimes we're seeing drug-resistant versions of these things. So it's getting a little bit scary as well. So again, counseling them on that. So Dr. Singh, I don't know if you want to make a comment around sort of things that you're seeing at DAP or any, what you guys have been doing to kind of address this growing issue.
Yeah, so we have DOC, which is like the STD clinic, and we offer PEP and PrEP over there. One of the reasons that could be increasing STI is we're checking it more. So because of PrEP, we just have them come in every 3 months and we check it more. Before PrEP, we were seeing them once a year or when they go to primary care or whenever they wanted to get checked. So some of it is kind of like a more frequent testing that's coming this light. But yeah, symptoms and asymptomatic conditions. So not all STIs are having symptoms associated. So exposure history, I mean, that's enough to get somebody tested and treated if they're positive or empirically, because a lot of STIs, they spread while you're still in the asymptomatic stage when then you're not suspecting it. So if, not necessarily they have to have a genital lesion or a rash or any of the systemic symptoms to get them tested. So test frequently, treat frequently, empirically if you need to, if you don't want to wait for the test to come back, but offer those services. Reduce the barriers to those services. So if they come in and there's a copay or something, and then that's a barrier, then that's something to be looked at. And the hours, try to have the clinic open at a time that when the patients need that access time instead of what's convenient to us, the 8 to 5. So we have some extended hours for that. And yes, the clinic is busy, so it definitely is quite prevalent in Palm Springs, the STIs. So
the CDC was looking. Oh yes, we'll get into it. Does someone have please? Yes, go ahead.
So, Dr. Singh, I just want to expand on that. So, would you also say it is imperative for not only just DAP, but for other general practitioners out there to learn how to swab correctly? In other words, asking those questions of what type of sex that people are having. Are they having, oral sex or anal sex, regardless of whether they're MSMs or women's, but that all providers as a whole become more comfortable asking those correct questions, knowing what type of test to perform to start with? Absolutely.
Being comfortable with getting sexual history is like the basic thing that all physicians, nurse practitioner, clinicians should do. I mean, we're so in what we do it every day, all day, every day. So it's very easy for us to ask like top, bottom, cervix. It's very, very easy for us. But yes, training and some education should be done for non-STI, non-HIV clinicians so they're more comfortable. And one of the things that I ask my patients is, can we swab everything today? It's not like, oh, but I haven't done anything. And I'm like, you're here already. Let's just swab everything. And they just make it very like, this is what we do every time. So there's nothing to like the risk stratification that was used to be done. I think that should be eliminated. Unless they are completely like, oh, I haven't had sex for like 20 years. Okay, well, maybe we won't swab you. But, if you are sexually active, you're here, let's just swab. It's very quick. It's not painful. Let's just do it. But definitely education for non-HIV STI clinicians, very important. Take the sexual history. I get records from other physicians that there is no mention of sexual history under, social history or anything. Nowhere. It's like, wait, did you, is this asexual person? Like you didn't, so. It's that part of history is missing.
Tulika, do you ever have any heterosexual couples come in and talk to you about you equals you, where he's undetectable and she's undetectable, and that they can have unprotected sex?
I don't have a heterosexual couple where both are pos, but I do have serodiscordant couples, and they do ask, so the male is positive and he's undetectable, and the female comes with him to the clinic appointment, and they will ask like, so does that mean we have to still use condom or not? And I tell them that, listen, there's always this viral blips that can go on. So there's always a chance that you could in between the testing, because you could test them today and they're undetectable and test in 3 months and they're undetectable. but in between. And I also see the history is like, you know what, you've been undetectable for like over a year. So chances that you're going to transmit to your partner is negligible, but there is always that chance. I never say 100% because I can't say that because I don't know what's happening between the two testing times.
There's a lot of publicity these days.
Yes.
You equals you, and it does raise a lot of issues and kind of brings up the fear too.
Yeah, I can say it was my family that you equaled you, and then there's no way you'll get it. I can't say that.
I do say that's my patients, and the ones that are undetectable have been consistently undetectable. I think there's enough data that bears out that if you're in a mutually monogamous relationship, even if you're serodiscordant, as long as the positive person is on their meds and they're undetectable, and they feel more comfortable having sex without protection, I've never seen an instance where a person in that situation has become positive. The only way that happens is that if the negative person wanders and has sex with another person, they usually get it from the outside. And that's what the strain analysis has shown, that the people in those circumstances who become positive are positive with the strain that is unlike the genetic strain of their partner's HIV. So it's, and then I say, well, if you're entertaining other guests and you're having relationships outside of your partner, then the rules change because you're going to be bringing in other people. So in those circumstances, yes, you need to be on PrEP, yes, you need to be wearing a condom, yes, you need to be doing all these things. But the practicality of the situation is you can tell people to use condoms, and if they're never ever going to use a condom, because let's say every time they put on a condom they lose their heart on it or something like that, then you have to deal with the fact that they're not going to wear a condom. So it's better to be honest with them and know the situation that's going on than to have them feel guilty and say, "Oh yeah, I practice safe sex all the time." And I think there's really good data out there to support the idea that if you're positive and if you're undetectable, you simply do not transmit it. And I don't care whether you're rocking and rolling or what kind of sex you're having or whether you're using recreational drugs. Because I followed a bunch of sex workers, and I had them thoroughly suppressed, and they had partners who were negative, where they had wild sex with all the time, and I tested them again and again. I did cultures for HIV. I did everything I could possibly do. This was way back when, and they never got infected. And so I think the idea that you have to consistently say wear condoms, wear condoms, wear condoms is kind of a separation from reality, because when you're talking to a person who never wears condoms, I think they need to hear a message that what they're doing is, the data bears out that they're not going to transmit the virus. But you have to say, but if people are, you're entertaining guests and things like that, then the rules all change.
Mm-hmm.
So you have to know them well enough to have them say, hey, I have a husband of 20 years, but I've got this going on the side, right? So in that context, maybe it's better to see couples separately because they can kind of confide in you as to what is actually going on. But oftentimes I see couples together, but I still ask them the same questions. I said, I know they're a couple and they're married and all the rest of that stuff, and I would say, are you guys having sex just between each other, or do you, invite over Elijah for dinner, right? So it's right. It's kind of the message has to be kind of blended with what they practice, and you have to come up with a kind of a medium that kind of makes sense. And the other thing is that especially in our community with all the meth use, once people start using meth, it's all rules don't make sense anymore, because then they stop taking their HIV medicine regularly, they become detectable, they get STIs, they have multiple sexual partners, so it becomes a really difficult situation to deal with them. I think the meth problem really needs to be addressed in a very kind of aggressive way, amongst our male patients as well as our female patients and the transgenders. Everybody's affected by it because the simple fact is that meth is cheaper than marijuana, and we're close to the Mexico border, and it's shuttled back and forth between Mexico and Palm Springs, so there's a ready supply of high quality meth that's cheap. And even meth dealers will go to patients who have gotten off meth, and they will give them free meth and get them hooked on it again. So it's something that we should be always talking about and trying to figure out how we can help those patients. Because once they get hooked on it, I have patients in their 70s who are using meth every day.
Crazy.
It's crazy.
Thanks, Dr. Scheibel. There's another question.
I just wanted to hear what Bridgette had to say.
Oh, I was just going to say, along the lines of the sex thing, it's really funny that a lot of our female clients that come in when we do sexual history, when we're rooming the patients, I find that they're quicker to say that they're not having sex and that they're not sexually active. I think out of a sense of guilt or like shame or that they shouldn't be having sex. And that's not the truth. It's a normal function of human life. It's part of affection. It's necessary for survival in some cases. And so if you are that woman or you know that woman, please, let her know that it's okay for you to be sexually active and have HIV as long as you're doing it safely. And there are safe ways to do that. And if you have questions about it, your nurse or your doctor can help you with that. But I hate to see people miss out on that healthy, stimulating part of their life out of guilt or shame, because we have a lot of that as women. And I don't think that it's not an additional burden that I think we need to carry.
Well, I think, I echo exactly what Bridgette has said. I've had several female patients, and as soon as they've had their diagnosis, that was the last time they ever had sex.
It's unfortunate.
And it's been going on for decades, and they feel frustrated, and they feel confused about dating because they want to date somebody, and then the issue of sex comes up, and it becomes very uncomfortable for them. And I agree with Bridgette. I think the women should be as sexually active as they feel they need to be.
Send them my way, Doc. I'll set them straight.
Yeah. And I think it's a shame in terms of women's issues that so many of the women just kind of shut down completely sexually. And I also think that, hey, we have ways that women who want to have families can have families now, and they can have HIV negative babies. And what a wonderful thing that is, to give a woman the chance to be a mom. And want to have those feelings of wanting to be a mom and wanting to have children and feeling like you can't have that option because you're HIV positive. And I've had women who have told me that, who have now passed their childbearing age, but they're regretful that they haven't had that experience in their lifetime because they wanted to have that experience. And I think that medicine is at a stage right now, we have the data that shows that, the women can have normal pregnancies and have HIV negative babies, and they can have families, and they can live long enough to see their kids grow up and become successful. And it's a wonderful thing to give back to the women, and that's been taken away by HIV.
Golkoo, the timekeeper game.
Yes, I've got to move on. This is great discussion, though. Thank you. Okay, so I think actually I can probably just quickly go through all this because we've covered a lot of it. Actually, Dr. Scheibel, thank you for covering a lot of it. But again, we have women who are, hopefully active in their sex life, and it's important to counsel them on, adequate birth control options. And so this can actually be a little bit tricky sometimes because there are HIV medications that can interact with birth control. And what ends up happening is sometimes the HIV medications can decrease the levels of the components, whether it be the progesterone or the estrogen, or can even elevate the estrogen levels to maybe a level that's not tolerable or can be toxic. And so it's important to consider that. And not all of the medications do have the same kind of interaction, so it becomes a little bit complicated in figuring out different options. But I think the medroxyprogesterone usually is a good option in terms of drug interactions. There probably are none or very few. So I don't know what kind of birth control, Dr. Singh, you guys tend to recommend for HIV positive women.
either, they're using condoms or they're getting the depots.
They're getting the
Yeah.
depots. Okay, yeah. So depot injection seems to be the way to go. And again, reminding them that the hormonal birth control pills aren't going to protect them against HIV, spreading HIV, getting HIV, or other sexually transmitted infections. And then, of course, we have women who are HIV positive and they want to get pregnant, as Dr. Scheibel mentioned, having families and being able to give birth to negative babies. And, things are relatively safe now. And actually, if women are suppressed, the chance of them transmitting their HIV to their baby is actually very, very minimal. And so, again, encouraging women that this can be an option for them if they are interested is a good thing. So if a woman is pregnant, hopefully that there's an OB there that can create a personal plan for that patient. Talking about different types of vitamins that they need to be taking, treating any of their STDs if they have, maintaining their healthy lifestyle, obviously avoiding some of these things like smoking, drugs, alcohol, practicing safe sex to avoid infections, and counseling on breastfeeding is not recommended. And then, of course, we have women who are in or near menopause, and they have issues as well. So again, having a discussion around the kinds of changes that they're going to expect during this time. And, Bridgette, Dr. Singh, do you have, maybe examples to share with us around women who are going through menopause or about to start menopause, the type of conversation that you might have with them?
I had my first hot flash. It was not pleasant. Just to have that open dialogue with your healthcare provider. It's important.
And in person living with HIV females, the menopause usually comes earlier than non-positives, and then also the symptoms are much harsher. And it's a little tricky to put them on hormone replacement therapy because you need sort of higher doses because of drug interactions. So menopause is definitely something that is an issue with older, and we have to screen for them. Like with the exposure of PIs or tenofovir in the past, they are more at risk for osteoporosis. So if they're younger, do the FRAX score, which tells us like what is their risk of fracture in 10 years. And if they're older, like postmenopausal, I say postmenopausal, do a DEXA scan. For males, we do have guidelines. Over 50 years of age, they've been exposed to ART. Yes, do DEXA. But for females, it's kind of like very blurry guidelines. It says if you're postmenopausal, do a DEXA. Well, they could be surgically postmenopausal since age 35 or 40. So I say I like a good age at 50 if they've been exposed to tenofovir PI for years. Just do, because sometimes we just do X-ray for something else and they'll show osteopenia.
Right.
In different.
Comment about that? Can you hear me okay?
Yes.
My name's Ann Stapleton. I'm kind of new to the Valley, but I was in Seattle for 30 years and took care of a lot of women with HIV. And I would definitely second what you say about menopause coming earlier. I never saw it come on time. It was always 4 to 5 years earlier. And I started doing DEXAs pretty like in the early 40s and finding osteoporosis, not just osteopenia. So I think till we get good guidelines, it's probably good to overdo the DEXAs if anything, and look early for the loss of bone, because very often these are long-term survivors who've got plenty of tenofovir, and who knows what else has affected them. So to me, that's a pretty critical piece of women's health with HIV, which is screening for osteoporosis and treating aggressively if they can tolerate it, and because obviously that's another whole can of worms. Is what's good for osteoporosis and what really works, and what will we be doing in 5 years? Hopefully better drugs, but at least try what we have for people at this time.
Great recommendation. Okay, so the last section, aging and HIV, so it's a nice segue into this. Of course, again, HIV is an inflammatory disease, and you're more likely to have comorbidities when you're infected. And so those include heart disease, cancer, osteoporosis, as we just mentioned, liver disease, kidney disease, and problems thinking and concentrating.
I know, Dr. Scheibel, I've had conversations with you about a lot of your patients getting older and them having kind of this really foggy thinking, and kinds of things that you've done to address that.
Yeah, I've got, it's not too uncommon when you talk to patients about, how's your memory, and, are you forgetting where you left your car keys, or when you park your car in the parking lot and can't find it, or, you left your door open and your partner said, why'd you leave the front door open? Are you crazy? That kind of stuff. And they say they're having these problems, and I'll ask them about their ability to remember things and stuff. And some people will say, I write extensive lists every day because otherwise I'll space out and I'll forget about things and stuff. And the thing that I've been doing is I've been intensifying their regimens with cells entry or Maraviroc. And cells entry is a CCR5 blocker, and it prevents the entry of HIV into a cell. And all the disease in the central nervous system is all CCR5. So it doesn't matter if they're dual mixed or if they're just R5 alone. The preliminary studies, which were done in Croy a couple of years ago, shows that over a 24-month period, there's improvement in neurocognitive functioning with Maraviroc intensification. I don't know why the Maraviroc people don't kind of promote more studies to kind of substantiate that in longer term studies, which would be very interesting. But so you have the aging of the brain, which may be HIV-associated neurocognitive decline, but you also have senile dementia, you also have Alzheimer's disease, you also have multi-infarct dementia, and Lewy body dementia and things like that. So you have the possibility that somebody has HIV dementia superimposed upon maybe a touch Alzheimer's and senile dementia. And when the gerontologist was here a couple weeks ago, we were doing that program, Dr. Green mentioned that, we're often kind of plagued with these various forms of dementia, which clinically kind of appear to be all the same thing. But I try Maraviroc intensification and see if that works. If you refer them to the neurologist, they're going to try them on one of the Alzheimer's drugs, and you'll find out quickly if it's going to be a help or not, because if it's HIV-associated dementia alone and not Alzheimer's disease, and you give them Alzheimer's medicine, they have all kinds of side effects right away, and they can't tolerate the medicines, which they immediately stop the Alzheimer's medicines. But I've had some good luck with Maraviroc intensification, even to the extent that people remember things better, they're better able to multitask, they're better able to do these higher cognitive functioning kinds of processes. And just as an FYI, you kind of ask yourself on Palm Springs, how many people are struggling with this HIV-associated neurocognitive decline? And I would say because our patients have had HIV for a longer period of time, we see a greater percentage of people, and we have an older population, we see a greater percentage of people with neurocognitive decline. So when we were screening for a study, which was the GRIFTA study looking at reduction of visceral adipose tissue and neurocognitive decline at baseline, when we were screening for those people who are interested in that study, we found that 80 to 90% of those people at baseline had neurocognitive deficits with our screening tools. So it's very, very prevalent.
Yeah.
And then the issue is, do you talk to your patients about their ability to think? Do you give them memory tests? Do you do any kind of testing to assess, if they have neurocognitive deficits? And then if you identify them, what are you going to do about that? And first thing I do is I get imaging of the brain, make sure there's nothing going on there as part of it, refer them to a neurologist often, and then intensify their regimen with cells entry and see if there's an improvement or not. If there's no improvement, you can always stop the cells entry because they're undetectable to begin with, so you're not messing up anything in terms of HIV resistance.
Thanks for that, Dr. Scheibel. So just in the interest of time, since we're running out of time, I'm just going to end it there. So if there are any questions,
I wanted to witness to Dr. Scheibel's use of cells entry.
Yeah.
He changed my medicines, and my mind did get freer. It cleared it up, and it helped a lot. So, and I've had HIV for 33 years, and nobody had ever run an HIV gene testing on me. I changed doctors and I lucked out.
Good. Good for you. Yeah.
I have a question for Mary and Bridgette. Can you tell us what are some of the things that have really pushed and helped you to thrive living with HIV, and maybe some things that you wish your providers kind of knew looking back that every provider should kind of know?
So for me, the thing that has pushed me to thrive is accepting HIV as being my truth. It is what it is. I can either, I say this all the time, I can either let HIV run my life or I can run my HIV. And that's what I choose to do. So that's how I thrive. It's my truth. It is what it is. There's no getting around it. As far as what I would have wanted a provider to know going in, I started out with providers who were accustomed to dealing with males. And so I think they approached me and my care from the perspective of, this is what I've always done. And women are a different set of, we come with a different set of emotional kind of stuff going on. And so that would be the only thing. I mean, once I expressed myself and talked about what concerns I had, the doctors were really fabulous about addressing those needs. But it's just getting a change in thinking, particularly because I started my care here in Palm Springs. So particularly in getting the mindset shift that men are different from women. The disease is the same, but the way that we deal with it and the way that we respond to the medications and things like that are different. That would be it.
Well, for me, I've always been motivated to take care of myself, except I did not accept it at all because I was co-infected with hepatitis C and HIV. And I was able to get rid of the hep C, which it's a whole different world now for my body. And I think going to socializing finally with Let's Kick Ass made a world of difference for me, because I couldn't say HIV and hep C in a sentence without breaking down, and now I can. It's like I accept it more. I'm freer with who knows. It's like, let's get rid of that. And but I think that having the socialization looked at has been one of the most beneficial for me.
Thank you so much for attending, and thank you to our panelists as well. If there's any other questions we didn't get to address, feel free to come up to us after. Thank you.